Okay, here we are, another episode of the Melillo Method podcast, Everything Brain. With myself, I'm Dr. Robert Melillo, and this is my cohort, Dr. Peter Scire. And we're excited about this episode because, one of the things we talk about is really, obviously the brain, what's happening with it, brain asymmetry, the problems that arise, the different conditions that we work with. And we always talk about that we can change it. But the big question is, how do you change it? How do you actually change the brain? And that's, I think, what makes what we do most unique, because there are other people out there that have some of the understanding of the neurology and of the brain and of functional connectivity and the hemispheric model and how it relates to mental health, people that we've talked about before and that we follow. But none of them have really developed a really complete model of how to actually fix it or change it or make a big difference. And I think that's the unique proposition that we have, is that, we have a way to actually change the brain. So let's get into it. Let's tell people, how do we actually do that? How do you actually change the brain? And let's give it a hint. It's not biochemical, right?
Yeah, and I think that was the contribution that you brought to our field, the functional neurology field, 25, 30 years ago, where we had the early development of the model of, okay, we can change the brain, the idea of neuroplasticity, the idea that you could provide a stimulus to a certain area of the brain and see changes in it. But you started going, okay, well, it's one thing to just direct one stimulus. What if we start doing it with multi-stimulus? And this multimodal program is what became the basis of the brain balance system on the brain and the basis of your Melillo method.
Right. Yeah, and that's the thing, when you talk about neuroplasticity as a definition, meaning the idea that the brain can change, but there are specific parameters. People use that term a lot, neuroplasticity. And one of the things we know doesn't cause neuroplasticity is medication. Or even most nutritional supplements. They don't really, they have an effect on the brain, but they don't really promote neuroplasticity. That neuroplasticity, by definition, takes a specific stimulus delivered in a very specific way, at a specific time with a specific repetition, to be able to literally change the brain. And so that's what I think people don't know or understand that. We look at our cognitive abilities, our ability to socialize, our ability to read other people, nonverbal communication, verbal communication. All of these are what we call emergent properties, meaning they emerge out of the brain as the brain grows. And, those abilities emerge out of the brain as it grows, but they don't necessarily in themselves cause the foundation of growth in the brain. And so that's the thing. I think a lot of people may talk about different ways to impact the brain, and they think about, well, the brain normally develops this way, and this normal stimulus at this stage of development, causes this to happen in the brain. But what if there's a mismatch? And what if the stimulus that's available doesn't match the actual physical growth stage of the brain? And so there's a physical growth of the brain that underlies most of the things that the brain does. And so that's the thing I think that a lot of people don't get. How do we cause the brain to physically grow and have those abilities emerge out of that growth? And then using those abilities will help to change the brain or refine it further. But those things that emerge as basically the cherry on top aren't the things that actually make the brain grow from the foundation.
Yeah, and those emergent properties you're talking about are these different neural networks that we're now understanding more at a higher level. We've talked about the central executive network or the salience network. But more specifically, what I think was a key for you was the fact that you said, okay, we can stimulate the brain, and how do these pathways work in a spatial and time orientation? And I think that that's where, when you came along and said, okay, rather than just do a singularity event to stimulate, because that was probably what was going on in the early years of traditional therapy and childhood development, like traditional OT or PT, was, very specific to one part of the brain, or maybe we're going to stimulate just the inner ear, the vestibular system, or we may do something with the ocular motor system and the visual system. But you said, okay, wait a second, let's do it in a multimodal fashion where we activate these pathways simultaneously in a very time-based sequence as well. And then obviously the bigger thing was the hemispheric aspect of it.
Right. Yes. So, to be able to use a combination of different stimuli. So, again, people will say, well, how do you change the brain? And so really physically, when we're talking the growth of the brain, the analogy I use is like building muscle, right? Meaning build a muscle, you need to use a specific stimulus. You need to use, let's say, a certain weight, or you need to do movement in a certain way to be able to grow that muscle. And, if I do something on my leg, it's not going to affect my bicep. I have to work on my bicep. Working on my left bicep is not going to work on my right bicep. I have to do something very specific, a very specific stimulus. Now, if I do the more intensity, the longer duration, the more repetitions I do, the more effect I get. And the bigger effect I get, the more efficient and the more I'll be able to do. If I don't activate or stimulate that area, if I don't use it, there will be atrophy of that area. It will get smaller. If I use it, I can get hypertrophy and it can get bigger than it normally would. And if I really want to train in a skill of how to use all those muscles together, I need to cross-train. I need to use multiple different types of training methods or different, types of weights or movements at the same time to be able to do that, right? And so the brain is like that. The brain, there are areas of the brain, and these different areas, as they grow and as they emerge, they will do different things. The back of the brain, the occipital lobe, is for vision or visual processing or doing things that have to do with eye movements. The temporal lobe is for hearing and for memory and for some emotional regulation and smell and taste. And the motor cortex is for movement and complex movement and simple movements. And the parietal lobe is for feeling our body and vibration and feeling gravity and vestibular input and, knowing where we are in space. And the prefrontal areas are where we have cognitive skills, and we have speech centers in the left side of the brain, and we have nonverbal communication in the right side of the brain. And so we have all these general areas, and then they're broken down into even more specific areas. And there's a difference between the right side and the left side. And so if you want to change the brain, you have to use a modality that's specific to the function. If you want to change the temporal lobe and the hearing area, you have to do sound. And if you want to change the right brain versus the left brain, you have to use specific frequencies of sounds or certain types of voices or certain types of words in music or emotions to be able to activate the left brain versus the right brain. And then you need to be able to, if you want to, change the whole hemisphere, you have to use multiple modalities. You need to use visual input and auditory input and smell and tactile and cognitive skills. And that's ultimately what evolved into, the Melillo Method. And what we do is the understanding of that, of first being able to measure it. Where are their deficiencies? What is the normal functional level? What should be the normal age of maturation that you can do certain things? And then how does that relate to the right brain and the left brain? And then how do we use different modalities to physically, literally change the brain?
And one of the areas that you didn't speak of was the cerebellum, okay? And how incredibly important the cerebellum is. And the fact that we have two cerebellums, we know that the one side of the cerebellum's surface area is that of the whole cerebral hemisphere, okay? And within that, these amount of neurons that are packed into that area of the brain. And, for a long time, conventional thought was that the cerebellum was really about balance and posture and muscle tone and motor planning.
Motor, right.
Yeah. But then all of a sudden, all that work that Jeremy Schamaman and his team did at Harvard, actually he's at Mass General, really showed the relationship of the cerebellum and cognition, and that really that the timing that you're talking about really exists between the input that's coming in from our muscles and our joint receptors, and our ligaments that are firing into our spinal cord, traveling up those spinal cord cerebellum pathways. And then the cerebellum is then receiving that information, receiving information from our vestibular system and our through our vestibular nuclei, and then taking that information and then firing it upward and creating that timing mechanism through those basal ganglia pathways that we've alluded to, that creates that synchronization that we're talking about. But we have to, as we've said in the past, drive that development from that bottom up approach. So one of the primary therapeutic treatments that we're always talking about is the aspect of muscle tone.
And that's, the thing when we're talking about, not only do we have to do things that are specific for certain areas of the brain and certain modalities and in different way for right versus left, but understanding that it starts with doing it at a developmentally appropriate level and understanding that the brain builds from the bottom up, like stages, building like a building. I always use the analogy that like the bottom of the brainstem, the medulla, is really the foundation of a building. And, until that foundation is solid, you're not going to really build these layers. And if you do build these other layers, they're going to be kind of unstable, or they're not going to be, as stable as they should. And you're not going to build a penthouse before you build the foundation, right? So that's the thing also, is that most people, when they think about the brain, they're only thinking about the brain. They don't really know, how does that brain actually develop? How's that? They see a building and they see the penthouse and they say, I want to be in the penthouse, but they don't see, well, what did it take? What were the materials that needed to be used? What was the blueprint like that actually was built before that, right? So this is where, looking at that brain developmental blueprint that we talk about, that the brain starts from the bottom up, and we need to use the appropriate stimulus at that level. And at the most basic level of the brain, it all starts with movement, and then with basic sensory feedback, primarily from our muscles, but then also from, and especially those big muscles along our spine, which is our primary driver of brain development in the beginning. And then it works its way up into the inner ear and the vestibular system. And as you said, that's all linked to the cerebellum and the lower brainstem, and then the eye movements and how that works. And these are the basic foundational, trio that really the whole brain is built on. And that is the foundation of it. And it all starts actually with those primitive reflexes that we've talked about before, that control that early movement before we even have a brain that controls any movement. So that's another key thing, is that it's not just providing a stimulus to the brain. If you provide a stimulus to the brain that the brain isn't capable of registering or responding to, because it hasn't been physically built, or it's not physically mature enough, or the timing is off, then that stimulus is just going to be wasted. It's like, building a house on sand. It's not going to last. And that's where a lot of modalities and therapies that are purely going to the brain, that's what we call top down, they don't work. Trying to get a child who's dyslexic to read and just say, well, they can't read, so let's make them read more, doesn't actually make sense from a developmental perspective. Reading more isn't what helps them read better. Doing things like promoting their movement and fine motor movement and getting rid of their primitive reflexes and providing them with the proper stimulus, and working on balance in their eye movement, that actually fills the foundation of allowing them to ultimately read. And that's kind of a perfect example of what we call an emergent property. And that's where people make mistakes.
Yeah, and when you look at the cerebellum, and as we look at other parts of the brain and how they're actually developing from a midline outward. In neurology, we talk about these midline structures, and our spinal cord being a very midline structure, okay? Our inner ear being a very midline, and how they're developing embryologically. And then we get into like these intermediate zones where we get more complexity of these pathways in the cerebellum. And then we get out to the lateral aspects of our cerebellum that we know that are tied to cognition. And as you were saying with the brainstem, okay, we have these lower parts of our brainstem that are doing very specific aspects to movement and eye movements and our vestibular input. But if we're not feeding those areas and those areas are not developing, as you said, those more lateral prefrontal areas are not going to come online. And as we've seen for 30 plus years, and for your career, and what I've seen with my career, is that, your parents go and they do these top down approaches, these cognitive based therapies or these behaviorally based therapies. But yet, when we see the child and they have these retained primitive reflexes, they have abnormal muscle tone or asymmetrical muscle tone, they have these problems in their vestibular system. We try to ask them to put their feet together, and even with their eyes open, they lose their balance. And then you ask them to try to close their eyes and they're completely falling all over. You see that underdevelopment. You ask them to try to track something, or even track their eyes in, or try to like do a letter H, and you're looking at those slow eye movements or rapid eye movements. They're all discoordinated.
Yeah.
But yet everybody's going, okay, but we got to teach them to read, or we got to have them write more. And you're like, go, wait a second, they got a motor timing problem, they got a processing problem that doesn't allow them to process visual input very quickly or auditory input very quickly. And like you said, bring that information together, create that timing sequence in the brain at that moment that allows that emergent property of cognition at, whether it's a comprehension skill or a math skill or a writing skill, to happen.
Yeah. So, it's exactly right. So let's talk about how we take all that information and actually practically do it.
Yeah.
So the first thing I want people to think about when we're talking about changing the brain is, one, it really doesn't happen biochemically. So the idea that medication or biochemical interventions, even diet and nutrition, really have
we're
that
not
much
supplement
of an
our way
impact.
out of this.
They have, they provide the proper energy for the brain to build. They provide many of the nutrients and the building blocks for them to build, and they're very important. But the stimulus is ultimately what builds the brain, right? That using something, use it or lose it, and using specific stuff. So as you said, we also have to take into account the developmental trajectory of the brain and do the right stimulus at the right time. We also need to combine multiple stimuli together to affect multiple areas of the brain to get those areas communicating. We have to understand that there's, a developmental trajectory with the right brain developing first and then the left brain. So there are different stages where we want to activate. We want to direct it when there's an imbalance. We need to direct it into the underdeveloped and overactive to stimulate one side and to literally reduce stimulation or inhibit stimulus to the other side. So the way that we do that is, again, we start with the bottom up, and it starts with movement, and it starts with sensory input. Sensory meaning vision, hearing, but the most basic foundational sensory is what we call proprioception and interoception. So it starts with, again, the first aspect of movement are these reflexive movements called primitive reflexes. And if those primitive reflexes don't come on and don't lead us through the right stages of building the foundation of the brain and building our core and our muscles, then right from the bat, we're not going to be able to grow the higher level functions of the brain. So that's where the first thing we look at is looking at, are these primitive reflexes there when they shouldn't be? And then we need to do things to get rid of them so that we can promote the best and the most optimal and the most complex movement, because there's a saying in neuroscience, simple movement, simple brain, complex movement, complex brain. Humans have the most complex brain and we have the most complex movement. And those two complex movements are standing upright and speaking. Those are the hardest movements that any animal has ever achieved. And we don't think about them because they're so easy for us, but they're so hard. And so anything that affects the child's ability to stand up and walk and talk and point and nonverbal communication is going to affect the development of any higher level cognitive skills. So it starts with, the first thing we do is we assess them. We start with primitive reflexes. We will do certain exercises. We'll stimulate them in a certain way, because when we're working with children or lower functioning people, they don't have control over their body yet. So we need to do things to them. We need to provide a stimulus like light or sound or smell or vibration or tactile. And we hit them with these different stimuli at different frequencies and directed towards one side of the brain more than the other. And that's the foundation. That's the first thing we do, whether we're dealing with adults or children. That's the first step. And then we work our way up.
Yep.
So doing things like vestibular stuff.
Yeah, or as we look at those retained primitive reflexes, and then with the vast majority of the children that we work with, when they have these very dramatic retained primitive reflexes, usually we're going to see these very low tone aspects. So now we go and we start having them do some exercises that allows us to measure the strength of their spinal muscles, okay, or their more these extensor muscles. Because again, as we've talked about, is that the whole basis of these primitive reflexes, and as we're staging through them, is really to take us from this fetal position that we're born in to bring us into this upright position, and this extensor relationship over that first 3 to 6 months, 9 months, because by that time that they're getting to that 9-month mark, they're now coming upright, and now they're getting more control of their neck muscles. They're getting more control of purposeful head movements that have a goal-directed relationship. And so now when they come upright, now we should start trying to see that we're trying to create that bipedalism mechanism. But usually when we have these retained primitive reflexes, we see these aberrancies in that motor planning, and then it leads into, like, let's say at 18 months or 2 years, 24 months, 30 months old, and so on, that now you kind of see this sloppy tone. This tone is just kind of like parents of, like, back in the old days, they would say it's Gumby, kind of thing. Now it's like, they kind of just feel stringy. They just don't have, and they're always constantly leaning on their parents, or they got to lean on something. And so that's where we have to look at that core muscle tone, and we take them through those series of exercises that we do. And then we immediately can see that they probably have balance issues, that can they stand just in a shoulder width position and look straight ahead without really bobbing all over the place. And if we are capable of getting them to close their eyes, and many of the children actually don't have the volitional control to actually consciously control their eyes. So, but if you do block their eyes and you put their head in various positions of extension or flexion, or even to the side, you see them lose their balance.
Mm-hmm.
And then again, you go back to that triangle of development where proprioceptive vestibular relationships. And now we start looking at these eye movements, and just basic eye movements, reflexive eye movements that we know, that we call actually this thing called optic kinetics, that it should be the first eye movement that appears that a child will have. We should get this rapid eye movement when we give them a very quick stimuli. We don't necessarily see that. And then we don't see the more finer movements of eye movements, the pursuits or saccadic movements.
Yeah. So we start with, again, looking at primitive reflexes. We stimulate the reflex and activate them, things like the palmar grass reflex, or the rooting and sucking reflexes, or asymmetric and symmetric tonic neck reflexes, tonic labyrinthine reflexes. We do these we literally move them, and we touch them, and we stimulate them, and it activates the reflex over and over and over. And ultimately, that increases the feedback into the brain and builds that next layer of the brain, which then comes down and then shuts off those reflexes and allows for a more complex movement.
But in some instances, though, when you do check for that reflex, right? Let's say we check for Babinski, and it's hard to produce it because there may be such a low tone.
Right.
Okay. Or we go and try to do
or they're not feeling it.
Yeah, they're not feeling it. Yeah.
Right. Yeah. So, by stimulating it, we're activating those tactile pathways that will help them to feel their body. And by building their muscles, we're giving them feedback to their body. And ultimately, the most important stimulus on an ongoing basis to grow the brain and maintain the brain is feedback from the muscles, because that is constantly there, especially our spinal muscles. And that is really gravity. Gravity is always pushing on us. It's the only constant stimulus that's there. So as you're talking about, we start with getting rid of these reflexes, and then we work on basic core. Even small babies can do a basic bridge, and we can get them to do that, where they're just activating those core muscles on both sides, because it's not just low tone, but then it's imbalance of tone.
Yes.
that really develops. And ultimately, even imbalance in tone of the spine can lead later on to back pain and neck pain and headaches and migraines and all different types of things.
Yeah, and the children that we see that maybe have more rare genetic disorders, or having maybe born with much seizure activity in their brain, one of the things that we do see is so much of that bilateral tone issue. Okay,
Yes,
and we see less of the asymmetric component of it, but
right,
there's an enormous. You look at their spinal muscles on each side, and you see that asymmetry, and
right.
so
Yeah, and that's where the asymmetry starts. It starts in the motor system
yeah.
where there's a difference, like looking at facial asymmetry, and we see a difference in tone where, for all of you, if you want to know if you had any asymmetry in your system or how you develop, look in the mirror or take a picture of yourself and see if one eye is bigger than the other, if there's less of a crease on one side, if your mouth goes down on one side, if you have a head tilt, if you have, different angulation of your body. These are imbalances in muscle tone that really lead to imbalances in the developing nervous system, and then also actually become part of that as well.
And you did a
And
great job in the new book, and then Disconnected Kids book part, as third edition. You did a great job of really being able to, again, explain them and give pictures of what those images look like. And you did it in the autism book.
yeah,
So parents should be able to go
for
in,
adults,
and
yeah,
adults be able to go in there and see that. But it's very evident. I mean, you and I are always talking about it. We see it, and we
right,
walking down there, Fifth Avenue, we can see people, and you can see that asymmetry in their posture, and head tilts and
hmm,
body angulations that indicate that, hey, one side might be firing overactively and one side is firing probably low.
yeah, and so we talk about that. Doing this in a developmentally appropriate way, according to this brain developmental blueprint, and causing the brain to grow and causing stimulus, and then being very specific to the brain. So we start out with more generalized type activities that really involve the motor system. So getting rid of the reflexes, stimulating them, tactile, without the child even having to do anything. And then we start with the big muscles, the core muscles, the midline muscles, which is the foundation of all movement. And then as they start to move through the world and start to stand upright, they're activating more, the neck and the vestibular system, as we're talking about. So then we can do things like, spinning them to stimulate, because then we develop these imbalances in the vestibular system. To, adults, it may show up as vertigo or dizziness where you feel, or motion sickness. But to a child, it ends up being, head tilts, body tilts. They're not developing a body map or a spatial map of where their body is. And so the vestibular system is built on that postural system. And then the oculomotor system, the way the eyes move, is interrelated very much with the inner ear. So making the eyes move in different directions or converging or diverging, but doing it reflexively, like you're talking about, because a young child or someone who's low functioning, they can't move their eyes. We know people that the first thing they start with is doing eye exercises.
Yeah.
That's a really high level
Yeah.
activity, right?
Yeah.
I mean, you have to
Different.
have your frontal eye fields, which is, part of your prefrontal cortex to really develop before you can really voluntarily control eye movements. So we do things called optokinetic reflexes. So we start with primitive reflexes, core postural reflexes, and then we start with the vestibular ocular reflex and the cervical ocular reflex, and then the optokinetic reflex. These are reflexes that are foundational for those systems. And those systems are all related to the cerebellum, as you're talking about.
Yeah. And which should be, as a child is born, should be there. Okay.
Right.
We should be able to take a young, child right at birth and be able to move their head and
Absolutely.
produce a vestibular ocular reflex. So
And they should be equal.
Yeah.
Right? Because that's another thing. Because people may say, well, isn't a lot of what you're talking about more traditional, like occupational or physical therapy? Don't they do stuff like that, like spin them or do, floor exercises or strengthening to a certain extent, right? But what they're not doing it is to understand that there's an imbalance. So you need to do the exercises more directed towards one side or the other.
Mhm.
You need to create the proper balance. In these systems, they're paired systems. The spinal muscles, the inner ear, and the oculomotor. They're these paired systems that are connected to the paired cerebellum at the most basic level and the right and left side of the brainstem. And if there's an imbalance that develops, which is at the foundation, then just doing spinning to both sides doesn't work. Doing adjustments to both sides doesn't really work. Stimulating tactile, doing smell, doing whatever you're going to do physically, if you do it to both sides equally, it doesn't establish a proper balance, so that it ultimately doesn't really have much of an effect. So it's not just doing those modalities, it's doing it again in the developmentally appropriate way. And very few people really ever look at primitive reflexes and know that that's the foundation. And if you don't deal with that, then those other things aren't really going to work very well. If you're not doing it in an asymmetric way, it's not going to work very well. And so those are key things. So it's not just doing those activities, it's how you do them and when you do them and how you combine them together. And that's unique about what we do. And that's where it starts. So it starts with those things: primitive reflexes, core stability, vestibular, oculomotor. And then we go from there, right? And then we start with sensory stuff.
Yeah. And let's give the context of what is the vestibular system. And so the vestibular system is these bony structures that we call the semicircular canals. And to keep it simple, we have, these three canals on each side, behind the eardrum, and we have a horizontal canal that's allowing us picking up head movements in a horizontal plane, and feeding our eye muscles that are actually going in almost like windshield wipers this way upon a head movement. And then we have our posterior canal that, as we tilt our head back into extension, our eyes are going to be driving down. And then if we come forward into a flex position, our eyes are going to elevate. And so again, we're going to have what we call this vestibular ocular reflex in relationship to these head movements. And then there's also another part of that structure called our otolith that's going to allow us to pick up linear acceleration of our body in space. So jumping up and down or walking forward and backwards. And so when we're assessing these children, we're really looking at that. We're really looking at the feedback from these semicircular canals firing in through the vestibular nerve into our nuclei that are sitting in that medullary, or the medulla and the pons area, that are then going to fire and control our spinal muscles, because we have vestibular spinal muscles. But then we have these ocular muscles or pathways that are going to our oculomotor nuclei that are control the muscles. And so again, we get this head movement and then the associated eye movement. And that's what we're looking for when we're assessing these kids.
Yeah, and that's the key, because those three systems, I look at foundational, they're interrelated, right? So you can't, stimulate your inner ear without moving your neck and without activating spinal muscles. You can't do that without moving your eyes, right? And your eyes are going to move relative to your head, and your head's going to move relative to your spine. Those three systems are interreactive. And if you have an imbalance in one, it's automatically going to create an imbalance in the other. If you have an imbalance with a head tilt, that's going to cause your eyes to move and create an imbalance in tone there. It's going to activate the inner ear differently. And then that's all going to feed back into the cerebellum, and that's going to feed into the brain. That's going to cause an imbalance in the brain.
Yeah, and we call these things like skew deviations in a lot of terms. And to your point earlier, you were talking about how now you get this sensory mismatch, and now you create this different map in the brain.
Right.
Okay, because we have these different various sensory maps that are built on the input that's coming in. So now you got a child that's walking through the world like this, and their eyes are like this the whole time. How is that changing that map in the brain?
Or not even creating the map. And that's part of the issue. I mean, we have kids, that we will spin them 100 times and they don't get dizzy.
Yeah.
When a child should get dizzy after 10 spins. And we see sometimes that, they get it to one side and not the other, because there's always this imbalance there. And that is, as they're moving through the world, feedback from your body and your muscles, and then from the inner ear and then the eyes, they create this triangulation that feeds up to the brain as it's building the brain. And again, as you said, creates this map in our brain, in our parietal lobe, and then in our insula. We have these maps, and vestibular maps. We have auditory sound maps. We have visual maps. And all of this tells us in our brain, especially our right brain, where our body is in space, called proprioception, right? It connects us to our internal feelings, called interoception. And then that lets us know where we are relative to other things. So as we move through the world, kinesthesia, we know where we are. And this enables us initially, when we're around 2 years of age, as the right brain emerges to actually realize that we become self-aware, we become embodied. We say, oh, this is my body. And at 2 years old, we recognize ourselves in the mirror for the first time and say, that's me, this is my body. And then once we have that, then we can have agency. We can now control what we do. And all of that is built on those sensations coming in and our brain registering it and doing it in a balanced way, because otherwise those maps get skewed or they don't get developed or they're not there, or we perceive like our center of gravity is here or here. And that's why some kids walk on their toes, not because there's a problem orthopedically with their legs or their feet or their ankles or their muscles are tight, because their brain is perceiving that the world and that their body is in a completely different place than it is. And they're falling forward and they come up on their toes. It's a spatial perception. So to be able to perceive our world and have spatial brain, which is the right brain, and all of that, which then leads to nonverbal communication, then leads to verbal communication and reading, and all those things are emergent from that. But it's about growing the brain. So it starts with motor input from those basic foundational senses, and then all the other senses like visual and auditory, which then develop from there.
Yeah, and I think that's been probably over the 20 years that I've been doing your work, probably the hardest concept to get our families to understand is the idea that the brain has to get this appropriate input. And for example, you have families that go to eye specialists and they'll talk about, oh, my child has strabismus or has this imbalance in these eye muscles, and they want to operate on the eye muscles. But no one has actually looked at the presence of retained primitive reflexes might be contributing that, or the lack of the vestibular input coming in that's contributing to the fact that, hey, these muscles are not growing, and that just because you go in and you try to shorten these muscles to try to create this ocular alignment doesn't mean that that's going to be achieved, because you haven't changed this input that's coming in.
Yeah, that's the basic thing like strabismus or, a lazy eye or an eye turning in or turning out. As you said, that's an imbalance between the muscles. And it always involves the vestibular system and it involves the eyes. And we often see postural, and many of those kids end up with scoliosis.
Yeah, if their head's tilting like this, what are the eyes going to have to do? The eye's going to have to counter roll. So if they're walking around like this, and then how is that changing the tonality from this side of the neck to that side of the neck and creating that mismatch, okay, or the way this vestibular system is perceiving the world?
And, I've never seen a kid with a lazy eye or an oculomotor that didn't have a cerebellar imbalance, right? That's the core of it. I remember I was teaching once and we had this neurooptometrist that was in the class and I was talking about this. And so she said, can I join you for lunch? She came to lunch and she said to me, so basically what you're saying is that, any sort of oculomotor like strabismus or lazy eye, it's never just a muscular problem. It's actually a central neurological problem and it involves the cerebellum. And I said, yeah, that's why I've seen many kids who have had eye surgery and their eye goes back to the wrong position.
Yeah,
why?
they're looking
Because
at it as a peripheral, it's a
muscle.
peripheral problem. They think it's a peripheral problem.
Right, they think it's a problem in the muscle, and it's not. The muscles are only responding to the signals they're getting, and the signals are unbalanced, so the eye is unbalanced. And so, I said, I've seen kids 2 or 3 times get eye surgery. And she said to me, I've seen kids get 11 surgeries. Now, this was an eye doctor. And it still didn't work, right? And you would think after one surgery, it not working, the doctor would go, oh, maybe I'm missing something here, right? And so that's a perfect example of, we're using this, really basic thing. It seems, okay, the eye turns out, let's do surgery to pull it out. Instead of saying, well, why is the eye turning in or turning out? And how does that relate to the fact that this child can't read or has a learning disability or has an auditory processing deficit?
Yeah, and the same thing can be said for all the AFOs that they're using on all these kids, okay? They're coming in and they're locking down their joints.
Yeah, those are braces that you put on the feet or on the ankles, again, when the kid is having trouble, let's say walking or something, and all that does is actually remove stimulus.
Yeah,
that
it removes the proprioceptive input. And yet, again, looking at the idea of this imbalance in the muscle system, but developmentally, is the imbalance there because we have this immaturity and no one is checked for the primitive reflexes, and no one has checked the integrity of this vestibular system. And once you start because we know that when we see the retained primitive reflex, like the asymmetrical tonic neck reflex or the symmetrical tonic neck reflex or the tonic labyrinth, and we see that, we know inevitably they're going to have an imbalance or in their vestibular system, because those primitive reflexes are hardwired into those systems.
Mm-hmm.
And we know they're hardwired into the oculomotor system.
Right.
So there's no way that how are they going to have proper vestibular spinal mechanisms? Okay, because everybody's looking at this, oh, it's proprioceptive. Well, yes, there is an imbalance in the proprioceptive aspect. There's heightened tone on one muscle group and low tone on another. But how is that related back to this big vestibular system that's firing on both sides and creating that? And I think that's, I think a model that's missing in the orthopedic model. And I know even as a trained chiropractor, so many times that we've been taught to adjust the spine and adjust these aberrant spinal positions, but in fact you start adjusting these patients and they're not responding, and then you put them on a force plate and that can measure their sway patterns and computerize it, and you go, wait a second, they have these aberrancies in their vestibular system, and you take it one step further and go, hey, check to see these primitive reflexes. So you got somebody that walks into your office that's got chronic low back pain, that's had chronic low back pain for 10 years, and they think that, yeah, it may have hurt because I injured it doing something, but in reality, it was probably sitting there for a long time.
Mm-hmm. Yeah, and most of these things are, again, neurological and developmental, and as you said, that basic orthopedic. I mean, I just spoke to a mom from England, and just so you know, I mean, anybody, if you don't understand, that in the United States we have the most innovative healthcare system in the world, and most of that is outside of traditional medicine, right? Because we have 10 times as many visits every year to non-traditional healthcare practitioners than medical practitioners. And though, people like us that are outside of that really are the ones that are the innovators. And in the socialized medicine world, they lack innovation, right? Because they don't encourage it at all. We can do a whole nother podcast on that. But this mom called me and she said, her daughter who had autism walked on her toes. And they said to her, we want to go and put braces on her legs to, stretch her Achilles. And the mom knew. She's like, I know that doesn't make any sense because it's not an orthopedic problem. It's actually a neurological problem, and it's directly related to her autism. And I've read your book, and I know your work, and I know, and we're doing your stuff, and we're seeing changes. And they said to her, you have to put these braces on. And she said, I don't want to put the braces on. They said, well, you have to put the braces on, and if that doesn't work, then we're gonna do surgery and cut the Achilles tendon. And she said, I don't want you, mutilating my daughter and doing that. And they said, well, if you don't do that, we're going to take her away from you. You're going to lose your child, right? Because you're not following what we, the government healthcare system, say you should do. And, it was completely wrong. It's not dealing with the core problem at all. It's neurological. It's in there. And it's a complete waste of time, but got to the point where, literally they're going to say, well, you're a bad mom, and we're actually going to take your kid from you. And I heard the same stories in Canada and many other places in Europe around the world. So it's, this simple approach because they don't know anything about the brain and the nervous system or the development. So again, it starts with us, what we do when people come in. How do we change the brain? It's not as simple as it sounds. You really need to know the brain. You really need to know how to grow it. It's a physical growth process that requires stimulus, the right stimulus at the right time in the right order. And it starts with, again, the primitive reflexes and the postural muscles and the vestibular and the oculomotor, and then different sensory stimulus like different light and frequencies of sound, different colors, eye movements, different lights, frequency of lights, sound, different types of frequencies of sound, low frequency versus high frequency. We start out with more prosodity or just hearing, tone of voice in a small child or even in the womb, We don't hear words. When words aren't stimulating the right brain as it's developing as much. It's really more sounds and the frequency of the sound and the low frequency of the sound, and more coming from the left ear than the right ear and going into the right brain and building that. And then eventually it's words, which having more impact on the left brain. And so we can use different frequencies of music or sound or words or non-words or whatever. And then we can use tactile and vibration, and smell is a huge stimulus that no one looks at ever. And we look at it on every patient, and it's almost absent or aberrant on every patient we work with from a developmental perspective, and we can restore it. The only time everybody thought about it was COVID. They didn't understand why. But that's a huge stimulus, so we provide that stimulus in a proper way. And there are right brain and left brain smells.
And I think the most important thing that we're able to do is that when we're evaluating them, we may have a child that's 5 years old chronologically, but through the evaluation process of looking at the sensory motor development and then cueing that into whatever neurocognitive skills that we can assess at that level of development, coming up with what we call a brain age and really saying, okay, hey, your child may be chronologically 5, but the symptoms that you're seeing, the symptoms in the social, maybe the underdevelopment in the social realm, or the emotional hyperreactivity, the tantrums, those things, as well as all the physical delays that you're seeing, when we assess, being able to say, okay, well, yeah, your child's 5, but yet developmentally, they are maybe 2 years behind. And more specifically, the developmental difference between one side of the brain versus the other side. And over the years, what you've been able to create is this idea of, okay, now we're going to specifically target these areas of brain, but based on the development of where they are right now, that gives us that window to say, okay, what ways are we stimulating? How long are we stimulating them for? And then as we start seeing these functional gains that happen, where now all of a sudden this child is saying, oh, we've seen over maybe a 12-week window or 16-week window, we've seen almost equivocal over 3 months, 6-month change in development. Okay, now they're ready for the next level of development, stimulation.
Yeah, so that age appropriate thing is so important because you look at it and you say, you wouldn't expect a child. You say, okay, we're going to teach 10th grade math to a 4-year-old. Mm-hmm. Doesn't make any sense, right? But yet if you see a 10-year-old that actually has parts of their brain that are 4, and you can't see that, you just see a 10-year-old, you're trying to teach him 10th grade math, and you say he should be able to learn it and can't learn it, so let's just teach more to him. But he's a 4-year-old brain. Yeah. It's never going to learn 10-year-old math, right? So that's the thing. You wouldn't, expect a child who's, 4 to be able to do exercises that you would have a 15-year-old do. And that's the thing. So we talk about like when, people that we really respect in the world of attachment and looking at brain asymmetry, and they talk about, well, at different stages, a child should be able to have the appropriate imitation. They should have eye contact. They should react to facial expression. And that builds that area of the brain in the right brain that will build their social cognition or build attachment to others. And, so that, if they're not doing that, then it must have been a fault of the parent that you didn't provide the right signals. You weren't doing that. And that's the whole thing. Like in the world of autism, they used to blame the mother and say refrigerator mothers, or with attachment disorders, they put all the blame on the parents or the caregiver. But what they're not thinking about is, yes, at a certain age, at 18 months or at 24 months, a child should get these signals that the mother or the father is giving, and they should react in a certain way. And if those signals there, a normal child will react, and that will build their brain. But if those signals are there, but the child is not old enough in their brain to receive them, and they don't respond, then that child's brain won't develop, and that skill won't develop, and it won't emerge. And then doing more of those signals isn't going to make that emerge. You have to, that's the thing they miss, the physical growth and development of the brain by using different types of first motor and sensory stimulation, and then very specific type things, and combining these modalities together based on an assessment that says what areas are deficient and what areas are overactive. And then we can, use more sophisticated sensory stimulation, specific types of colors or light or visual input. And then we get into visual processing abilities, which is built on the ability to see and hear first, and then processing skills. And then we get into cognitive skills like memory or attention or social cognition or speaking, or doing math or doing calculus. Those are things that emerge later on, and we can do those things, but at the right time. And then we need to fold into that, providing the nutrition, making sure their gut and everything is closing up and working properly so they have the energy, they have the building blocks to build the brain at the right stage when you provide that stimulus. And all of this needs to be done, understanding that we're trying to mostly create balance into the brain. And that's how we grow a brain. And then we add things like timing and rhythm and coordination. And then we can do other things, and top-down type skills will work, like behavioral interventions or, neurofeedback or other things. And that is what we do. And that's the uniqueness of what we do. And that's how we actually stimulate the brain. And to be more specific, I have a good description of it in Disconnected Kids, where we really talk about it, and especially now the new version that just came out on looking at primitive reflexes and how to stimulate them. And that's still a basic format. The Melillo Method is much more complex because then we can add all different types of sophisticated stimulus now, like transcranial direct current and alternating current that can be used to target specific networks and broadband areas of the brain and ramp them up and inhibit one side and activate the other. We can use laser therapy and light therapy, infrared and red light to change frequencies of the brain. We can use other types of electrical stimulation. There's magnetic types of stimulus. But as we've talked about, that has to be done in a very directed, specific way. And most people don't understand that. They just generally do it. And if anything, it doesn't work at best. At worst, it makes things worse.
And I think one of the misnomers that's been out there for many years is that you're saying that we're going to concentrate the stimulus towards the underactive side with the benefit of bringing balance to the brain. That's the thing. Because some people are like, oh, all Dr. Melillo is doing is just stimulating one side. And they're like, you're stimulating one side with the intent that as this side matures, we're going to get inhibitory mechanisms that are going to happen to in most instances, that overactive side that's there, because we have this imbalance in the vast majority of kids where we have this one side that can be 2, 3 years, 4 years, even maybe 10 years difference in development from one side to the other. So the ability to raise that area up. And now what you're talking about with these newer technologies and the advent of your work over the last 5 years is allowing us to say, okay, how do we slow down this overactive side that we've known for years, not only clinically, but now the research is continuing at your own lab, but also other people's labs that have come out and say, hey, one of the hallmarks of these disorders, autism or ADHD or OCD, is this hyperconnectivity that we see, this very intense focal connectivity that's happening on this one side, specifically the left side. And so the question for years was, okay, we can raise the right. We know we can raise the right. We've shown it in the Harvard study and we've shown it in other papers. But now the question was, do we have to sometimes lower that? And I think that's, talking about emergence, that's where you're taking your work now.
Yeah, because the more severe the imbalance, the more deficient and the more delayed development is. So then when we're working with kids, let's say on the lower end of the autism spectrum, that can't speak at all and have no control over their own body, and they're stimming all the time, their left brain is so powerful. They're so genius in that left brain, but it's so overactive that we realized that just stimulating the right brain alone wasn't going to be enough, because the right brain, when we stimulate it, inhibits the other side. So we're always working on both sides. And again, if you have an imbalanced system, you have to do it in an unbalanced way. That's where, if people say, oh, you're only doing one side or you're stimulating one side. Yeah, because that's what you do in an imbalance. If you stimulate both sides, you don't change an imbalance. Yeah. But taking down the other side, as we stimulate one, it inhibits it and it brings it down. But we have these kids now, or these kids with really terrible tics or
Yeah, I
whatever.
mean, we saw it for years that it wasn't happening.
That it was a perfect example in Kevin James's daughter, like to be able to try to get that right brain to emerge. If we didn't take down the left and bring it up, and if we didn't have these newer technologies like the transcranial and the lasers, there's not a lot of ways to really slow down or quiet down the left brain so that we can get that to come up. And that's where some people will say, well, don't you still want to stimulate the other side? No, because everything they're doing all day, every day is feeding their left brain. And so you need to completely leave that alone and even slow it down to even have a chance of getting that right brain to come up. So I think hopefully this is giving you a better idea of what we do when we talk about everything. The question is always like, well, what do you do? And how do you do that? And how do you change the brain and stimulate the brain? And so I think we've given you some of the foundations of it. Obviously, it's pretty complex stuff, and it needs to be directed towards an individual. And there's all different types of imbalances, but we talk about it in large conceptual terms so people can understand it. There's a lot of deep neuroscience under this that very few people in the world understand, and even less can actually change it. And that's, I think, what I'm most proud of, is that we developed a program that can change it in a way that really nobody has at this point. So hopefully that's giving you some answers about that. And, you can read more about it in my book. And we'll talk more about it as we go on down the road, being more specific to specific conditions and what do we exactly do. But I think that gives a good foundation for people.
Yeah, I think the whole concept of doing this podcast was about, how do we take this complexity of neuroscience. And I think over the years, you've done a great job in writing these layman books. But at the end of the day, we also know when you teach and you're teaching to a group of professionals, it's a very intense course that you're doing. You're teaching about 150 hours of academic work for people to get certified in your program. And so how do we take that and translate that? Because this information is so complex, and
Right.
And sometimes you don't want people to just perceive it as, oh, okay, all I got to do is shine a light into some kid's eye, or I just got to hold a laser over their head.
Yeah.
It's far much more complex than
so
that.
much more complex.
And so when the criticism comes of this, it's like, oh, this is just talking about this simple right brain, left brain dynamic. No, we're talking heavy neuroscience.
Yeah, this is the most complex system in the world. We just are pretty good at making it sound simple so that people can understand it, which in and of itself is a feat.
Yeah.
Right. But yeah, so that's what drives me crazy. It's a very complex thing, and it really takes, a certain level of expertise, even though we can teach people somewhat to do it. But that's why it drives me crazy when someone says, do this one exercise. Anxiety, ADHD, bipolar, autism, they're incredibly complex. Human behavior is incredibly complex, and it's built on so many different factors. Yeah. And so to just say, do this one exercise to end anxiety, or do this one thing and it's going to cure depression, or take this one pill and it's all BS. It doesn't work that way.
It just gives me good laughs on Instagram every day.
Yeah, it's just, they're just trying to sell something, but it doesn't work. So if you hear that, just ignore it. It doesn't work. It's more complex, but anybody can learn how to do it for themselves. Anybody can learn about their own brain and can learn how to change it. And that's what I've written in my book. So, all right, we'll talk more about this next time. Thanks for us today. Thanks, Pete. I think this was great. And we'll see you next time.